Hello, everybody. That is my disclosure. I'm a consultant for a nutritional company. Let's start with that definition of CAM and integrative medicine. So CAM stands for complementary alternative medicine, and that is really everything outside of what we think of as conventional medical school style medicine, though osteopathy is on the integrative side, definitely, with some of the practices. And then integrative medicine is trying to integrate all the different parts, whether it's allopathic medicine, complementary alternative medicine, and putting them all together, utilizing all effective means and working with other disciplines for the benefit of the patient. Integrative medicine is also extremely patient-centered, which of course we're all in medicine moving towards. And as you hear more and more about integrative medicine, you actually recognize that it's just really practicing good medicine. We have an extraordinarily expensive healthcare system here in the U.S. That black line on the top of all those nice little colored squiggly lines is healthcare spending in the U.S. We pretty much double the nearest candidate for spending on per capita spending on healthcare. And this is what we get for it. This is from an IOM report on comparing the U.S. healthcare system to that of 16 other developed nations. And this is looking at life expectancy, and the males are dead last in that list. The women are 16th out of 17 nations. So we're spending twice as much, and we're not getting very good value. This report, which was called an International Perspective, Shorter Lives, Poorer Health, showed that we were really the worst off of these 17 nations, and that our health has been deteriorating over the past 3 decades consistently, and this affects even relatively well-off Americans who don't smoke and who are not overweight. It isn't just the people who are uninsured and poor, it's all of us. They called it the U.S. Health Disadvantage, and if you haven't read it, it's available free online on the website where all the IOM reports are, and it's very, very interesting. Why do patients turn to CAM and integrative medicine and spend, in 1997 it was estimated, $30 billion a year out of pocket? They must be feeling that they get something for it, otherwise they wouldn't continue to do it. It was General Eric Skumek, the former Surgeon General of the Army, was talking about our healthcare system. We had just presented all the data on how poorly America is doing in healthcare and how much we're spending, and he said any system that persists is obviously meeting its goals. And if we've just heard what the health of the nation is, so obviously the goal of this healthcare system, its purpose for existing, is not to promote the health of the nation. So what is it? The system of CAM and integrative medicine is growing and persisting, so it must be filling some purpose. Now, when we look at the strengths of allopathic medicine, it's really good at acute conditions, trauma, fractures, strokes, heart attacks, accidents, wonderful. You know, if I'm smashed up in a car accident, please don't take me to the massage therapist or the naturopath if I need emergency room care. And these things warrant highly invasive, very costly, very risky interventions. But what really is the majority of what we face as practitioners? We face people who have chronic diseases. 7 out of 10 of our deaths each year are caused by chronic diseases. We have 133 million, almost 1 in 2 members of our population have at least one chronic disease. And the vast majority of our healthcare costs are also going onto chronic disease. And there's the reference there on the CDC. I'm going to redefine what a diagnosis is. I think a diagnosis is an agreed upon category. There are certain times where a diagnosis triggers a reaction that's extremely warranted. So somebody comes into the emergency room and they have an appendicitis. You want to get that diagnosis quickly, and you want to fall into a pattern of treatment that is pretty automatic and doesn't really involve a lot of steps of thinking along the way. Same thing if somebody comes in cardiac arrest or any other serious emergency. But when we're talking about a lot of the chronic diseases, the criteria are fuzzier, and the need to keep thinking about the components of extremely complex chronic conditions we're faced with patients, whether it's diabetes and all of its complications, whether somebody comes in with fibromyalgia, or many of the other things that we're seeing. Really, I like to look at a diagnosis as just a collection of symptoms and findings, and then I like to look at it more granularly, beyond just the diagnosis. So I deconstruct it. Many of the component systems can be managed. So, for example, somebody may come in with a diagnosis of chronic pain and sensitization of the nervous system, and they may also have some arthritic condition. They may have a few degenerative disc issues. They may have myofascial pain. They may also be eating a really poor diet and have vitamin deficiencies. In this climate, we're all vitamin D deficient unless we supplement. Vitamin D deficiency is overrepresented in chronic pain populations. They may not be getting enough exercise. They may also have poor coping skills. They may not know how to self-soothe. They may have trauma in their background. And if you pick apart all those factors, you have more things to work with. When we look at medical education, standardly, what do we miss? We miss out on nutrition. So most of us who graduated conventional medical schools have had a few hours of nutrition education. We don't learn much about exercise physiology, sleep, stress management, whether it's our own or others' stress, work-life balance for our patients. And these are all important things to recognize. I always like to throw up this slide because this study was pretty dramatic. They followed 23,000 people for 7.8 years in this study. The acronym is EPIC. They were identifying 4 behaviors: not smoking, exercising for 3.5 hours per week, which is just half an hour a day, eating a healthy diet as described there, and having a BMI under 30, which is not, it's just on the verge of obesity. So we're not looking at super skinny people here. Well, it was a vast reduction in cardiovascular disease, in cancer, and most of the chronic diseases were dramatically reduced. Blood pressure was also reduced, and the figures were higher than anything you could expect from any drug. And this is all lifestyle medicine. This requires us to collaborate with people who are effective coaches for helping people change their lifestyle. This is what a nice, healthy, good diet should look like. That's what a diet should not look like. It doesn't mean that nobody can ever eat this stuff, but when I'm taking a diet history, I am very careful about making sure I know how much of this stuff people eat. And when I tell them, when they're counting their tally of what their food is at the end of the day, none of this on this page is actually counted as food. This is World Health Organization data. These color codes tell you calorie content, calorie intake in different countries. The darker the colors, the more we're eating. Guess what we are? We're the darkest color. We're eating over 3,500 calories per day per capita. No wonders we're having some dietary issues. It's all about choices. So I tell my patients that they change their body chemistry every time they eat, that they can increase their inflammation or decrease their inflammation based on their choices. This is a pictorial version of sugar in different Coca-Cola sizes, and those are sugar cubes in the front. When you see it graphically, it can be pretty shocking in terms of how much sugar you're getting in these foods. And this is a hidden source of calories. Sugar creates increased inflammation. It also makes us overeat. Sugar is as addictive as cocaine, and it is in 80% of the processed foods that we manufacture in the U.S. We even put sugar into savory foods. So ketchup has an inordinate amount of sugar. Processed meats in this country also have sugar in them. And the food industry knows this and purposefully has done it with the same level of conscientiousness that the tobacco industry has done it. They have purposefully created things that are addictive and bad for our health. Glycemic index is something I explain to patients that tells you how fast a food turns into sugar. If it turns into sugar quickly, then it is going to spike your blood sugar and increase your inflammation. Now, sugar has a glycemic index of about 62. Most of the processed cereals that we have on our grocery store shelves have a glycemic index above 70, some of them as high as 80 or 90. The healthy ones, and that I'm saying in quotation marks, things like whole grain Cheerios, like Special K, like the whole grain Chex, most of those are well into the 70s, which means that it would actually be healthier to eat out of the sugar bowl because it would spike your sugar slower than the boxed cereal. 85 to 90% of the carbohydrates that we consume are high glycemic. The anti-inflammatory diet is high in these foods and not in processed grains. Pulses are in the legume family. Lentils are pulses. This is a quote from Walter Willett from Harvard, who has written a good book called Eat, Drink, and Be Healthy and done many studies on anti-inflammatory diets. Okay, so now for some specifics in terms of pain levels, but I do want to reinforce that all of the dietary advice is also specific for pain. People do feel better when they reduce their soda and sugar intake. And I understand you recently had a wonderful success with a patient and headaches who you took off sugar. Vitamin D levels in this Mayo Clinic study were associated with higher opioid intake in terms of dosing and also in duration of use. And what they concluded was that vitamin D inadequacy is an under-recognized source of nociception. If you check fibromyalgics in particular, they tend to be very low on vitamin D. And replenishing their vitamin D can often bring their pain a notch down. I've given you some references here on vitamin D research. Magnesium is extremely helpful. It causes muscle relaxation. Calcium causes muscle constriction. And when I explain this to patients, they understand immediately that they feel that their muscles are contracted and tight, even if they have pains in the abdomen or arthritic pains or other conditions. They almost always recognize that there is a muscle component to it, and I contend that there is a myofascial component to the majority of the pain syndromes we see. And note that myofascial component is amenable to treatment, and that holds for fibromyalgics as well. There's quite a few publications looking at the overlap between fibromyalgia and myofascial pain, and there's a Venn diagram that has a lot of overlap to it. And so if you address the myofascial component, you can often decrease the overall body pain and improve function. So magnesium, some of the science behind why it works is that it inhibits release of acetylcholine from the motor end plates. Magnesium depletion gives you neuromuscular excitability, also produces tremor, cramps, and tetany. There's some recent rat studies looking at NMDA receptors and nerve pain that are quite interesting. So we've known for a while that there's a site for magnesium on the NMDA receptor, but there's a recent model of neuropathic pain that involves nerve ligation. By using NMDA, by using magnesium, they're able to ameliorate the development of pain. They've also done a similar model with micronized progesterone, and they were actually able to completely eliminate the development of neuropathic pain in the rats that were pre-treated with micronized progesterone. I often use micronized progesterone in the perimenopausal years, but given that study that came out, and given that progesterone is the safe one of the hormones, it doesn't have the risks of estrogen, it's not prothrombotic and carcinogenic, and it's also not feminizing, so it could be used in male and female populations, so I'm keeping an eye on that research. So side effects of magnesium: it improves constipation or irritable bowel. It can in fact be a complete treatment for irritable bowel if you simply tell people to take enough magnesium to have 1 to 2 easy to pass bowel movements per day. Now, if they're already saying that they have regular bowel movements, tell them to take as much magnesium as they can without inducing diarrhea. It's also very important that magnesium needs to come from a good health food store or supplement store as opposed to a drugstore. The standard drugstores tend to carry the magnesiums that induce diarrhea and to do colonoscopy prep, so they don't have the good quality ones. It's helpful for sleep disorders, for pain conditions, for cramping, for bone health, collagen formation. It's essential for forming collagen. So in order to make good collagen, you need vitamin C, magnesium, and sulfur. And sulfur can come from foods such as the allium family, which is onions and garlic, from ginger as well, and from eggs. The adverse effect with overdose is diarrhea. Vitamin B12, this is a study of injections of vitamin B12 in people who had normal vitamin B12. Each arm of the crossover that was getting the active B12 had improvement in pain and reduction of analgesics. Side effects you can see here is that it's a very powerful methylator, which means it helps with mitochondrial function, which is ATP production, and in detoxification functions. It improves sleep as well. It's been associated in some studies done in Great Britain with preservation of brain volume in those over 65. All of the study subjects in that study had normal vitamin B12 levels, so even within the normal range, the higher the better in terms of preserving brain volume. Again, it's an association. We don't know if it's cause and effect. It is a cofactor for methionine synthetase. It lowers homocysteine. A Framingham study found unexpected B12 deficiencies in in young people. A lot of people are on PPIs, proton pump inhibitors, which get a slide of their own. They're so high on my not to-do list. And B12 deficiencies can occur from antacids and PPIs especially. And it may be helpful in diabetic neuropathy, fatigue overall, and fractures. It used to be in the 50s and 60s that women would go to their doctors for B12 injections and felt it was a tonic. That went out of style by the time I was in medical school, but it's actually coming back into fashion with some good scientific evidence behind it. Turmeric, there's some interesting studies coming out there in osteoarthritis that Agarwal is doing, looking at post-op pain. He's a surgeon, and he's trying to reduce the side effects from the surgery itself as well as from the analgesic use after surgery. He has not yet been able to show decreased stay times in hospital, but he has been able to reduce side effects post-op and reduce opioid use and analgesic use. The side effects of turmeric is that it's neuroprotective. There are studies being done on Alzheimer's prevention and reduction of Alzheimer's symptoms using turmeric. Glucosamine, the studies that have been done seem to focus on 1,500 milligrams per day. Glucosamine sulfate is the most studied of the preparations, but it could be glucosamine hydrochloride as well. Studies lasting up to 3 years is what they've been able to show in the Cochrane reviews. Exercise and spinal manipulation have been shown to be more effective than medication for acute neck pain in an NCAM study. So NCAM is the Complementary Alternative Medicine Division of the National Institutes of Health. We're very good at starting patients on medications, and I often see patients who've been through many physicians before, and we seem to be much better at starting patients on drugs and not so good at getting them off drugs. So we don't seem to have an end game for, how long do they stay on? Do they stay on? Are we really born in states of drug deficiencies? And should people be on these drugs lifelong? One good case in point with Vioxx, the data about cardiovascular risk was actually done in studies before FDA approval was given for Vioxx. To have 160,000 excess cardiovascular and cerebrovascular events before it was withdrawn. And even now, non-steroidal anti-inflammatories that people can get over the counter and stay on as though they're candy, they cause more deaths per year than HIV. 16,500, and those are only in the diagnosis of rheumatoid arthritis and osteoarthritis. People take it for much more than that. This is the study reviewing the deaths. This is other data showing that asymptomatic users of NSAIDs, 71% of them have small bowel injuries on endoscopy. So PPIs have had a black box warning on them for the last several years, and yet every day I see people coming into the office who've been on PPIs for years. I had a trainee here from family medicine who, after hearing of my diatribe on PPIs, went back to family medicine and shared the information that the FDA recommends that people shouldn't be on them for longer than 3 months. The side effects of prolonged use, which can be profound and life-threatening magnesium deficiencies, calcium deficiencies, osteoporosis, B12 deficiencies, hypergastrinemia, which is implicated in pancreatic cancers, rebound hyperacidity, protein malabsorption, dysbiosis, and C. difficile. And she went back to the unit, presented the information to the other family medicine residents. They took a sampling of 100 or so charts, and they found that well over half of that population had been on PPIs for many years, and nobody had considered removing them. And so they're having a project to get people off of PPIs in the family medicine department. I initially got excited about this because of B12 and magnesium deficiencies quite a few years ago, because those things impact on pain. And then when the FDA came up with their black box warning, I got totally rabid. Statins are another drug that I think we need to be cautious about. If you look at the research on statins, the research is supportive of using it for secondary prevention, but the most widely used indication for statins these days is primary prevention. And the number needed to treat is somewhere between 67 and 140, which makes the average number needed to treat somewhere in around 100, which means that in primary prevention settings, you're treating 99 people in order to prevent one event. In the past studies, they used to look at all-cause mortality. When they did statin studies, they stopped using that as an endpoint because statins did not turn out well looking at all-cause mortality. They reduce coenzyme Q10, which is essential for mitochondrial function and also for cell membrane function. So it causes myopathies. Now, when prescribing them, I've noted that people get told early on that they may have muscle pain, but years later when people develop other diagnoses, fibromyalgia or some arthritic changes and they're achy, everybody just forgets the fact that the statin may actually be the root cause. I'm often able to negotiate with the patient and whoever their prescriber is to take them off of the statin for a period of 3 months' time and see how they feel, and also see what their cholesterol does. We can have a long discussion on whether cholesterol is actually a useful endpoint measure. We seem very attached to it, and oxidized LDL is probably much more indicative of actual risk from a cholesterol moiety. Well, I always find it's useful to get people off. If they've had a previous cardiac event, I won't. I'll just put them on coenzyme Q10. If you look at the basic science literature on coenzyme Q10 and statins, it's pretty definitive that this is an important thing to add back into people's diet and to do it through supplementation. If you look at the the cardiology research and the cardiology opinions, there are many cardiologists who will prescribe it on an individual basis, but when you look at the consensus of opinion in their literature, they're wishy-washy. But I do have a slide of a quote from one of the articles which says, well, yeah, we do know we deplete coenzyme Q10, we do know it causes myalgias, but we don't have enough evidence yet to prescribe it. In fact, we are more comfortable prescribing drugs with known morbidities than we are with prescribing supplements with very few morbidities but questionable efficacy, when the basic science indicates that it may be useful. Now, we're all waiting for large-scale randomized controlled trials, and there has to be, those are extremely costly, and most supplement companies don't have the money to fund those large-scale trials. There was a really wonderful review by a statistician on the unreliability because of all of the different levels of statistical error that happen in these large controlled trials. Okay, so these are trigger points. Myofascial pain is under-recognized, and this is evidence of trigger points. You can see that when in the color picture, that is elastography that highlights a dense area of muscle that is stiffer than the rest of it. That is a trigger point. This is normal muscle, which doesn't have a trigger point. So we now have evidence of these. And what we should all remember, this is from Rachel Naomi Remen, who wrote some wonderful books, Kitchen Table Wisdom, My Grandfather's Blessings. The most basic and powerful way to connect with another person is to listen, just listen. Our presence with a CE is the best gift that we have to give our patients. And I know you do get some talks on mind-body medicine, and that's where this flows into.